Hi, everyone. Welcome to the North American Spine Society Journal podcast. My name is Tobias Mattei. I'm the deputy editor of NASSJ, and I have the privilege of having with me today here Anne Stuedemann and also Dr. John Anderson. They were authors of an article published at NASSJ entitled "Can Oral Caffeine Decrease Postoperative Opioid Consumption Following Posterior Spinal Fusion in Adolescent Idiopathic Scoliosis, a randomized placebo-controlled trial." Thank you for your time today.
Yeah, thanks for having us.
Perfect. So before we go into the details of your study, would you be able to highlight, probably to our listeners, what are the mechanisms of analgesic mechanism related to caffeine? I think most spine surgeons may be a little bit familiar with the use of caffeine, maybe for intracranial hypotension, people use for migraines because of the vasoconstrictive effects, but I'm not sure everyone is very familiar with the receptors and how this pathway of pain control is affected by caffeine. So if you want to start with that, maybe.
Yeah.
Go ahead, Andy.
So caffeine, as we know, is adenosine antagonist, and it attaches to all types of adenosine receptors. Now, when you think of stimulants, you think of things like methylphenidate, where they primarily, affect like dopamine and norepinephrine levels. But caffeine as an alpha antagonist affects all alpha in both the brain and the spinal cord. So alpha 2, alpha 1, and that alpha chain is known for its nociceptive properties, its anti-nociceptive properties. And so that is where we kind of got the idea of using caffeine for pain. Also in adult literature, it's been studied and paired with other over-the-counter medications like ibuprofen and Tylenol and been used as a pain medication.
Okay. Is there any other, either in the orthopedic literature or any other literature that you saw that it has been used successfully in the perioperative setting for maybe some other type of procedure? Is that what prompted you to kind of investigate in the setting of spine surgery?
It has been used in adults with a lot of dental procedures and some smaller procedures. We didn't see any pediatric literature referring to caffeine as an analgesic. And we also, when we did our lit review, as you know, for spine surgery, it's been used. There's a lot of literature with caffeine in the neonate population, looking at its neuroprotective agents, properties of it. Also, it's been researched in like athletes and how their muscle endurance and their performance and their perception of their muscle soreness and how caffeine has improved that. There's some good literature out there on that. And those were kind of the supporting articles that we had to use it. We thought that with muscle, obviously with spine surgery, you're also causing a lot of muscle injury and you have a lot of muscle soreness. So if an athlete, that kind of helped with that athlete's perception and their overall soreness, that maybe would help with our patients' perception of their muscle soreness. And neuroprotectant with neonates, well, we are working on the spinal cord. We're all about neuroprotective agents. And then just from being a stimulant too, we have Dr. Anderson, with return to bowel function after spine surgery, we just saw a lot of benefits to that.
Okay, that makes sense. So try to give us some perspective in terms of your sample size and the method of administration of caffeine, your population, and then after that, some of the results you found.
Yeah, can you say the first part of your question again? I've lost track of it already.
Perfect. No, so if you want to just highlight the sample size, because one of the things that I look at this study personally is that I was wondering, I know that there's some tendency of valuing only positive clinical trials or those that show a difference. And I know I'm giving the result a little bit to our listeners, but you were not able to show a statistically significant difference between both groups. And that probably it's related to the low sample. So I was wondering first, what was the sample size calculation and how did you base that on how much did you want to achieve in terms of reduction of morphic milliequivalents so that you your study definitely gives an idea of the therapeutic effect for future studies based on that possible 5 morphine milliequivalent reduction during the hospital stay. But you started from scratch. So I'm wondering how you ended up with this sample of, I think it was 24 patients in the caffeine group and 27 patients in the control group.
Yeah, I think, we were powered. Our power analysis, gave us a number of 68, I think, to reach adequate power. And we fell short of that for several reasons. One is just the study drug on for quite a long time because of COVID. And then we also had we were doing the study in a period of time where our peri-operative pain management protocol really changed a lot. And it almost got to the point where it was very difficult to continue on with the study because the way that we approach pain and our patients changed so much that we were kind of using almost antiquated methods of managing their pain that we used years and years ago. And it just got to be kind of a little bit of a hassle to keep doing the study and recruiting patients. A lot of it is, we've shifted away from PCAs. We've shifted away from using intrathecal Duramorph. And it just made continuing with the study to get those additional, what do we need? I guess 17 more patients to reach our power. It just made it very difficult to continue on.
I understand.
And when doing a clinical trial, I think that it's really important to, when we first started out, we're like, this is orthopedics. That's our first, big clinical drug trial, prospective, double-blinded. All we have to do is standardize things, and that's going to make it easy. But what you're forgetting about with drug trials is that you're standardizing not just orthopedics. You're standardizing anesthesia, nursing. And that's in the beginning of our study. We had a big, and you can notice in our consort diagram, we had a pretty big drop in eligibility. We had a lot of kids who were disqualified or weren't able to complete the study. Just from, I think, 20% of our rate was related to study protocol breach. Because once again, you're trying to standardize all these multidisciplinary groups. And just, I also think that's a huge step forward for our institution is at the time, right now we have a lot of enhanced recovery after surgery pathways. We're having a lot of institutions that are standardizing. But when we first started this in 2019, the ERAS system was very novice at that time. And so we had 3 different spine surgeries. We had multiple anesthesiologists coming in out between our spine surgery rooms. And so I think it was a big movement forward for our institution to start standardizing things. So we did what this study kind of pushed us to do was start standardizing anesthesia and standardizing our post-operative protocols. Yeah, now, standardizing with nursing is really difficult because you have so many nurses that rotate through a surgical floor. And to try to provide education on protocols, especially strict trial protocols, was incredibly challenging. And nursing don't follow dosing guidelines on what is their verbal analog scale. Nurses often try to pre-anticipate pain. So before physical therapy, they'll just automatically give them a higher dose of pain meds, knowing it's going to hurt. But this protocol, this trial really made them have to dose their medications off of their pain score, which is a huge change of practice for our nursing. So just across the board presented a lot of difficulty.
Yeah, and so as someone involved with clinical investigation, I mean, I know that even conducting a trial, regardless, even if you finish the trial, is already a tour de force and a learning experience that goes far beyond any possible retrospective review or whatever other type of study you may engage on. So and that's why I wanted to highlight this study because, I mean, even though the results were negative in terms of being able to demonstrate a therapeutic difference or benefit in one group, I think it established at least what could be an effect size for future studies, and we can discuss what you found in that regards. But especially, I mean, it seemed like a well-conducted study based on a very reasonable hypothesis with an underlying pathophysiology. And I mean, we all know the side effects of opioids, and as much as people may be a little bit weary about caffeine and in children, I mean, clearly this short-term exposure is likely less harmful than whatever marginal addition of opioids you would need for that population. So congratulations on the efforts and on this publication. So tell me a little bit about the results. How did you measure their pain and what were your overall findings comparing the caffeine and non-caffeine group?
Well, we measured our findings. We recorded, what we did with standardization is every child, we chose hydrocodone at the time as our primary post-op opioid. And so what we would do is according to that patient's pain scale. So 0, if they rated their pain 0 to 5, they got the lower dose. So we dosed it per weight. So so it was dosed at 0.15 per kilo. And then with the lowest dose of hydrocodone, so we had 2 different doses. Like, so for example, if you had a 40-kilo child, we had a 5 milligram hydrocodone on there as a choice for a VAS pain score of 0 to 5. And then we had the higher dose at 0.15 per kilo at 7.5 milligrams. We kind of rounded it to the nearest tablet, or rounded down to the nearest tablet. And so that would be for a VAS pain score of 6 to 10. And then all of their multimodals were standardized. Everybody was on ketorolac up until day 1. Then we switched them to scheduled ibuprofen. They were all on scheduled Tylenol. And then we'd also have PRN Valium, which we documented in the study as well, how often they needed breakthrough Valium. And then we calculated the MME for the mean MME, and then the mean MME per kilo. And then we did per day, and then for the entire hospitalization as well, for both the placebo group and for the caffeine group.
And the patients also received a pre-op dose of gabapentin, followed by, I think, was it three days worth of scheduled gabapentin post-operatively as well. And the hydrocodone dose was a high dose and a low dose. It was 0.15 milligrams per kilogram for the low dose group and 0.2 for the high dose group. And then we gave a numerical value to that, I think, as well. They gave them 1 point if they took the low dose and 2 points for the high dose. We kind of had several different ways of looking at their overall opioid consumption.
And besides opioid consumption, you also evaluated some of the possible cardiovascular secondary effects. So do you want to expound on that a little bit?
Yeah, we really didn't find that the caffeine group they didn't have an increase in their blood pressure or their heart. We actually found that their heart rate was less on post-op day 2 than the observation or the placebo group. I'm not sure what to make of that, but everything else was the same or equivalent as far as their blood pressure and other hemodynamic markers were concerned.
So no secondary effects that would be deleterious related to caffeine. And I know at the end of the paper, you highlight that, I mean, even though, of course, applying the null hypothesis significance testing, there was no statistically significant difference. So for all purpose, I mean, you could not prove a benefit of adding caffeine to that. But just comparing the numbers on both groups throughout the hospital stay, it seems that it was the equivalent of 1 dosage of Norco that the patient in the caffeine group was able to forego. Is that kind of overall your...
That's right.
And I think, honestly, looking at that, I think that's one of the main most important findings for future studies. I mean, it would. I mean, with this dosage that you evaluated, if any future study wants to conduct a power analysis, and I think that's what you could reasonably expect, that this dosage would lead to a 5 milligram reduction throughout what is 2.5 hospital stay average that you had, and then you can evaluate the sample you will need to evaluate. Does that make sense?
Sure it does, yeah. Yeah, we found pretty much that the overall MME per kilogram, I think all those things were less in the caffeine group, but they just didn't reach statistical significance. Now, if we would have had enough patients with, maybe we would have gotten there. It's hard to know. We'll never know, I guess.
So what is the future you think for investigation of caffeine in the setting of spine surgery? I mean, do you see, I mean, maybe a new trial, more well-powered trial, or is this something that at least lays the ground in terms of the concerns that caffeine may have any deleterious effects? So it kind of provides, I mean, definitely the field is open, and at least for me, it was very instructive looking back at the pathophysiology. I was not aware of all those cascades and networks and receptors involved on how caffeine could not only affect pain directly, but also potentiate other anti-inflammatories and reduce the opioids. So, I mean, it's definitely an open field.
Yeah, it was, I have to hand it to Ann because I really took interest in using caffeine post-operatively for return of bowel function. that was my original intent. And because we've been giving caffeine to kids postoperatively for years prior to doing this study. But mainly my thought was it would improve return to bowel function. But we just started to notice just anecdotally that the kids who were on caffeine just seemed to be much perkier, and they seemed to be getting up and moving around more and in a better mood. But then Anne was really the one that stumbled upon all this data regarding, the scientific basis of it being a nociceptive agent. And I was really quite oblivious to that. And I'm not sure why, considering it's such a, routine drug added to other over-the-counter pain medications. It just never crossed my mind, really.
So maybe based on what you're saying, I mean, maybe there may be even a room for future studies on the issue to evaluate constipation, or even to evaluate participation in physical therapy, right? Because I mean, even though the reduction in the narcotics may not be that meaningful, I mean, if you have patients that have documented bowel movements earlier and they're participating in the therapy on an average much earlier than the other group. I mean, that may be part of the therapeutic effect that you want to achieve rather than just the isolated VAS number or opioid consumption, right?
Mm-hmm.
And speaking to our lit review, there are articles out there supporting caffeine in high-end athletes with their perceived muscle soreness and things like that. We still use caffeine in our practice today. Our postoperative patients across orthopedics, if they qualify with weight and age, we'll dose them with caffeine because we do see those kind of properties of them just being more alert, more willing to get up, and have they have a lot less perceived what we think as perceived muscle soreness.
And can you share to our listeners, I mean, I know you seem to have an extensive experience with that. I mean, what would be the recommended dose and for how long you would keep that you think in your experience is safe and reasonable? I mean, even though, I mean, looking at the data, we still don't have the clinical scientific evidence for that, but what do you usually use or what would you recommend?
We usually use 100 milligrams, and we've been using 100 milligrams. It is said that over 400 milligrams a day is bad, and so you don't want to go over 400. We also have to take into account routine caffeine consumption. In the hospital, you don't get a lot of caffeine, to be honest with you, as a patient. It's not, we offer sodas and things like that very frequently. And so we can kind of control their caffeine consumption. And even if they had coffee or something on top of that, it wouldn't put them over that kind of threshold. Also, we kind of dosed it off of pregnancy safe dosing. Nothing above 200 milligrams has been documented for pregnancy. So we just do 100 milligrams twice a day. We do this on our older kids. So the study said over 40 kilos, and we kind of abide by that from a patient standard today as well.
And would you do that throughout the hospital stay, as many days post-op to discharge?
We do not discharge them on caffeine.
Okay. No tapering those at discharge?
Yeah.
Okay.
It'd be interesting to see, what the results of this study would have been if this was done, 15 to 20 years ago, prior to, coffee being such a popular beverage in this country. Back when I was growing up, I don't, young people didn't drink coffee. Now teenagers drink coffee all the time since there's a Starbucks on every street corner. And I think the number of adolescents and pediatric age patients that consume caffeine has probably gone up.
For sure, no, exponentially, right? And it's not only coffee, but I mean, if you see the amount of energy drinks, so I mean, one of the thoughts that this brings to mind is that you may not be fully convinced about the beneficial effects of caffeine in terms of pain reduction, but you definitely don't want your patients in withdrawal in the post-op spine surgery, right? So you have someone who's drinking 2 Red Bulls a day, and then you do spine surgery, and the last thing we think about is that, I mean, they are miserable and they're sore and they cannot participate of the therapies. And part of that is they're going through caffeine withdrawal throughout the hospitalization. So, I mean, that's definitely something that came to my mind, and I will be paying attention rather than just focusing on the major smoking issues or the medical comorbidities. Knowing this effect upon the not only the level of activities, but the muscle spasms and the perception of their muscle pain. It's something that I think every spine surgeon should be aware.
Mm-hmm.
Anything else you would like to highlight to our listeners?
I don't have anything. I don't know about Ann, but
Yeah, no, it's I think it's also just important to do clinical trials, to do evidence-based practice, to set standards. If anything, the study, when compared to other studies done in the past, kind of noticed that our MME per kilo for our mean and between our days kind of correlated with other studies. So from a benchmark standpoint for pain control, and it's just good information to have out there. So just to always encourage, prospective studies.
For sure. So in the name of NASSJ, I thank you for your submission to our journal, and thank you for your time today. And we look forward to seeing more submissions from your group and publications. And have a great day.
Yeah, thanks for having us.
Thanks for having us.
Have a nice weekend.
You too.